some lady comes to you with even normal blood glucose, but if she had bad obstetric history, just give a small dose of insulin. And I said, what could be the culprit? There's nothing else coming out. He said it could be the glycemic variability, which might be the culprit, where you don't have an exact cause of the fetal loss the lady had in the past. And that's why we should certainly be respecting. One is insulin, and of course second is glycemic variability, to have smooth control. So we should not be just relying on one blood glucose, and that's why everyone says you do fasting, you do post breakfast, you do post lunch, you do post dinner. And if you are on type 1 diabetes or type 2 non-diabetic, go for even pre-lunch and pre-dinner and pre-breakfast also. So 8 points monitoring is good. CGM is good, but then CGM has to be for 9 months, and it is only for 14 to 15 days. Then you have to then select that who was the right candidate who can really put CGM and takes their insulin according to them. Seems very difficult, but type 1, pre-gestational, type 2, they might be definitely benefited. May not be of very much use for type 2. And let me also share, when it comes to scientific evidences, CGM has got the scientific evidences done only for type 1 diabetes, and there is no evidence for type 2 or GDM. Unfortunately, CGM is still not being approved in India for its use in pregnancy. It's going to be an off-label use. Let me first take you to the few important things. How do you define GDM? There are different ways of defining GDM in last few years. GDM, everyone knows that it is a hyperglycemia diagnosed between 24 and 28 weeks of gestation with standard criteria. It could be IADPSG, it could be DIPSI, it could be WHO, it could be ADA, anyone. But any hyperglycemia between 24 to 28 weeks, and they used to call it as CGDM, that is conventional GDM. That's a new terminology, some of the authors have used it. There's another case which is called as overt diabetes, or recently FIGO has classified in 2015, if I am not wrong, as diabetes in pregnancy, DIP. That means those who are being diagnosed, those women who are being diagnosed to have hyperglycemia in pregnancy, earlier they were not aware of it, but that particular cutoff during screening has come as that of the non-pregnant state. That means hyperglycemia diagnosed during pregnancy, satisfying the standard criteria of WHO for the diagnosis of diabetes in the non-pregnant state. That means they were pre-existing, usually type 2 diabetes, rarely type 1 diabetes, but they had never tested their blood glucose earlier. And one should know today, the recent data of ICMR June 2023, it says we have around 140 million pre-diabetes, around 14 crores, and we have around 101 million, that's around 10.1 crores, they are diabetics. So 14 crores of pre-diabetics, 10 crores of diabetics, almost 25 crores. That means today only I was going through the news, and it says that we have around, how many number of voters we have? So around 97 crores 97 crores voters we have. That means 18 plus individual in our country is around 100 crores. And if you just see that 14 plus 10, almost 25, so every fourth individual, I repeat, every fourth adult above 18 years of age might have either diabetes or pre-diabetes. And these are the women amongst them. Almost 50% of them are going to be women. So every 8th woman, whether you're pregnant or non-pregnant, you are likely to have pre-diabetes or diabetes. And that is why we should be more focusing on addressing this thing in the very, very first trimester, or even at the time of conception or preconception, that we should not be missing out these pre-diabetes or diabetes, and they get conceived and they come to you with high blood glucose. So now the mild GDM is when your GCT value is 2 hours is more than 140, we call it as GDM. But when we know that our target goal of postprandial is 120. So when it's above 120 but less than 140 is called as mild GDM, or gestational glucose intolerance by DIPSI, or some of them say, earlier we used to call it as isolated abnormality of blood glucose, or IGT in pregnancy. So all these categories should be known to OBGY, so that you don't miss out the mildest form of hyperglycemia or the severest form of hyperglycemia, which is suggestive of pre-existing diabetes but diagnosed for the first time. So these two categories, overt diabetes or pre-gestational diabetes, are the categories which need insulin more. So here is a umbrella terminology used as HIP or hyperglycemic pregnancy, which is divided into DIP, diabetes in pregnancy, those who are diagnosed before the start of the pregnancy, or so known type 1 or known type 2 diabetes becoming pregnant, diagnosed for the first time during pregnancy, that is clear-cut case of GDM, but they are not clear cut case of GDM, either could be type 1 or type 2, and those who are diagnosed early. So this is DIP. So most of the DIP category, I repeat, most of the DIP category will require insulin therapy to achieve glycemic targets of 90 and 120. 70 to 80% of the GDM women who are classically appearing with milder form of hyperglycemia, usually in the 24th, 2nd, 3rd trimester, they might do well with nutrition therapy in 70% of the cases, but 20 to 30% may need insulin. But DIP category, most of them will need insulin therapy even if they are on metformin. So a target is 90 fasting, less than 90, some of the recommendation is 95, but 90 has been recommended by most of them. 2-hour value should be less than 120, that should be, you should remember. So remember two figures, fasting 90, 2-hour less than 120, that should be a target. And as I told you in the discussion, that you should be monitoring fasting, post breakfast, post lunch, as well as post dinner. So let us come back to the with this base of understanding that which are the individuals who are likely to need insulin therapy. Insulin is the preferred medication for treating hyperglycemia in pregnancy. Metformin glyburide should not be used as a first-line therapy, as both cross the placenta, but Government of India guidelines as well as European guidelines recently have come out with the favorable statement for the metformin, and that's why we do give metformin also, but insulin remains the drug of choice. Metformin, when used to treat PCOS and induce ovulation, should be discontinued after the first trimester is over. But insulin should be used in type 1 diabetes 100%, and it is also a preferred drug for type 2 diabetes in pregnancy. Multiple doses of insulin therapy or insulin pump can be used for in type 1 cases. This is 2024 ADA recommendation. Now there are some absolute indication for insulin therapy in pregnancy. Those are coming with very high HbA1c, coming with ketonuria, those who have associated renal dysfunction, hepatic dysfunction, macrosomia, IUGR, hydramnias, or steroid therapy. Such patient will need insulin absolutely, and they cannot be just controlled only on oral drugs. So let us take this whole story in few cases, and I will not be very much into detail of each case. I will be focusing more into therapeutic aspect of it. So this is a 28-year lady, housewife. First pregnancy, she was diagnosed to have diabetes in July 20, and she presented with hyperglycemia at 28 weeks. She was positive for COVID, and she also had moderate ketosis, and she had IUD there locally. Now this lady has fasting C-peptide, which was done 2 weeks after 2 weeks of IUD, which was low, so suggestive of either type 1 diabetes or LADA. And she presented to us in August 2000. So very next month she presented with HbA1c of 12.9, and the preconception counseling was done, and she was asked to be on multiple doses of insulin therapy. She was hospitalized for control of blood glucose. Basal bolus therapy was given, and she was put on insulin glargine and regular insulin for 3-4 times of regular as well as once a day long-acting insulin. Preconception counseling was done. She was taking treatment regularly through teleconsultation after she visited us in 2020. 1 year after that, she came with ANC with 9 weeks. This was a G2, and she had 1 IUD, and she has pre-pregnancy weight was 63, BMI was 23, so not obese. HbA1c at the time she was diagnosed was 12, but now it was 6. That means good preconception care as far as HbA1c is concerned. There is no associated macro angiopathy. Let us see the insulin, which we have our main aim for today's CME is. So if you just see the total dose of insulin, this is pre-breakfast, pre-lunch, and the pre-dinner, and this is a total dose is around 44 units per 24 hours in pre-conception. And as the 10 weeks, 22 weeks, 32 weeks and 36 weeks, as the pregnancy advanced, it went up from 44 to 96, 124, almost 136 units, and at the end, around 36, 37 weeks, the insulin requirement went little down. Post delivery, it came down to 20, that means 50% of the pre-conception dose, and within 30 days after delivery, it went up again from 20 units to 54 units. So 0.7 unit per kg body weight pre-conception, which is also being shown in one of the type 1 data we have, and then it went up to almost two and a half times the 2 units per kg body weight, and when came back to 0.8 unit per kg body weight after delivery. So this is how you are supposed to monitor cases. If you see long acting insulin, traditionally we teach people, even most of the books they say you should have 70% long acting, some says 50% long acting, but if you just see in pregnancy, you have 20, almost 68 units of short acting insulin and only 28 units of long acting insulin. That means pregnancy is a state of postprandial hyperglycemia where you need postprandial to be controlled with high doses of insulin and dietary therapy, while the long acting insulin requirement is less, and that has also been proved in recent data. And there's a very recent data which even Dr. Uday Thalala sir or Bhavatarani have not shared in any of the meeting. Possibly some of the meeting have told that there's a data of HAPO follow-up study, FU study, HAPO study from where the IADPSD guidelines have been designed. Now there's a follow-up data of these patients, and it has been shown that the follow-up data of the offspring of mothers is more the offspring who has got obesity or other risk factors is more correlated to the postprandial blood glucose in pregnancy than the fasting. And here again it signifies that they are requiring very high dose, and if you go with the book language what is being given to you, possibly will not be able to justify the therapy in this women. And that's why at the end of any CME, any good doctor will tell you okay, you should be individualizing the therapy. So this is how it is. It is a postprandial. If you see, this is there's another thing. One is the breakfast, lunch and dinner. If you see the post-break, pre-breakfast, pre-lunch and pre-dinner, the pre-dinner dose seem to be highest, and this is how it goes from the pre-conception. It went up to 36 weeks. After 36 and 37 and 38 weeks, it may go down. This postnatal went like this, 20 units, and then after 30 days it went up to 54 units. So this is how the insulin in type pre-gestation, LADA or type 1 diabetes. LSCS was done, 36 weeks, required intrapartum insulin infusion, 3 kg weight, so normal weight baby, no congenital malformation, lactation, she is breastfed, and the weight gain during pregnancy around 14 kg because she has normal body weight. Insulin regimen, premixed insulin to be avoided, basal bolus therapy has to be preferred. Intrapartums, your target should be 70 to 120 intrapartum, and if suppose most of the GDM women may not require any insulin during the delivery, but most of the pre-gestational type 1 as well as many of the type 2 diabetes might require insulin infusion at the time of intrapartum phase. Those who fail to do that, in that situation we ask them to monitor blood glucose frequently and give subcutaneous insulin therapy. Now this is the chart which has been already there in the Government of India guidelines, that how you should be adjusting the doses of insulin infusion. The case number 2 is twin pregnancy. So it is 24-year lady already on metformin from the rural India, metformin 2 gram per day, and glimepiride 2 milligram, and sitagliptin. Out of that, let me also remind you all gynecologists here that the glimepiride and sitagliptin are contraindicated in pregnancy. This was a type 2 diabetes already taking these medication. It was an accidental pregnancy, and I always say 90% of the pregnancies are accidental pregnancies, and only 10% of them they go for preconception counseling care, and they stop all these contraindicated drugs, and they have been shifted to insulin, and they monitor blood glucose, try to achieve less than 6.5 of HbA1c. But at 6 to 8 weeks she came with this, so already organogenesis is already over, and she was on the same treatment till 7 weeks of pregnancy. Past history of GDM, and she was on insulin, but she was uncontrolled, and she had premature birth as well as one missed abortion in the past. Fasting was 250, postnatal 277, HbA1c 8.1, BMI was almost normal. Mother has diabetes and she was admitted. She was put on basal bolus therapy and metformin 1 gram per day. And her dose now 8 weeks it was around 0.5 unit per kg body weight, 18 weeks 0.7, by 36 weeks almost 0.8 units, almost 1.5 times increase. At day 30, postpartum day 30, she was only on metformin, and 180 days, that is 6 months, because she was having breastfeeding and we preferred insulin, she again was put on premixed twice a day insulin therapy in the postnatal phase because she was hyperglycemic. So this is type 2, but one should remember that even for 1 month she did not require any insulin dose type 2 diabetes in postnatal phase. So here again, if you see the long-acting insulin again seems to be quite less. The short-acting insulin was high, 10, 10, 10, 30 units. Only long-acting only 3 units. Here also almost 3 or 5 units. So very small dose of long-acting insulin, and the requirement of short-acting at breakfast, lunch, and dinner was quite high. And this is the graph for type 2 diabetes. So she delivered at 36 weeks, no insulin required intrapartum despite being type 2 diabetes requiring high dose of insulin. Baby was twin pregnancy, one was 3 kg and or 2.7 kg. It is very much unlikely. Most of the twin will have both this small for gestational age babies, but this woman has coincidentally and fortunately did well, and no congenital malformation. Weight gain during pregnancy was 19 kg. And this is the postpartum 30 days blood HbA1c 6.5, blood glucose well maintained. Later on she was put on premix twice a day, and then basal bolus therapy again she was shifted in October. The mortality rate of these babies is almost 50%, and in our case one patient was diagnosed to have type 1 diabetes during around 28 or 29 weeks of pregnancy. She presented with diabetic ketoacidosis. She was traveling from Ahmedabad to Nagpur, and from here to some part of Madhya Pradesh, but she landed it from the airport directly to ICU, and she was in multi-organ failure. Baby was already dead, but we could save the mother. She had multi-organ with sepsis and all that. But this is one case. There are 2 more cases which were presented to us in our own OPD. And this case was out of them one could not be saved. The baby could not be saved. Mothers, of course, all 3 mothers were all good, but one of the baby we could save even treating ketoacidosis with standard method. The only thing is that such patient with type 1 diabetes need to be told about the prognosis of such cases with diabetic ketoacidosis. One baby we lost out of them after she left from here after maybe around a week or so, after correction of ketosis. So not necessarily that you will have a intrauterine death during the ketosis, but it can even be after that. So we have this data coming from diabetic ketoacidosis, one paper, 77 diabetic ketoacidosis, 64 pregnancies, which was published in Diabetes Care. Fetal demise almost 15%, premature birth almost 46%, and NICU admission almost 59%. Maternal admission, of course, will be higher with higher serum osmolality. Insulin GDM now. GDM is more prevalent. 85% of hyperglycemic pregnancy they are going to be GDM. So GDM at the time of breakfast, lunch, and dinner. If you see, as the pregnancy advances, this is diagnosed at the time of diagnosis. At the time of delivery, there is increase in the dose at breakfast, lunch, as well as dinner. But if you see from the baseline itself, the pre-dinner dose found to be higher than the pre-dinner dose was found to be higher versus the pre-breakfast dose in all the pregnancies, which again says that this particular population in central India actually have higher calorie intake, and that's why they require higher dose at the dinner time. This is our paper which was published in DCC, IJDDC, and which was on type 2 diabetes insulin therapy. First trimester they require around 0.5 unit per kg body weight. Third trimester around 0.8 unit per kg body weight. That's all we have shown in one of the cases also. And this again mean insulin doses. First trimester and well as third trimester, the pre-dinner was found to be highest versus but the long-acting insulin, again if you see here, bedtime dose of long-acting insulin was smaller than the short-acting insulin 3 times a day, and which is correlated with the breakfast, lunch and the dinner calories in this population may not be true for South India. The case 3 is a case of GDM. So GDM housewife from Nagpur, ANC 20 weeks. She was again underweight, positive family history, and her insulin dose, if you see, 0.13 unit per kg body weight at 22 weeks, which went up to almost 0.4 unit per kg body weight, and then almost 0.6 units, and then delivered a normal baby of 2.6 kg, no neonatal complication.